Hello everyone, my name is Trosakan. I'm a second-year resident at Verde Valley Medical Center, Midwestern University Internal Medicine Residency Program. I'll be presenting a case on primary cutaneous CD8 positive aggressive epidermotropic cytotoxic T-cell lymphoma, or AECTCL. Cutaneous lymphomas are non-Hodgkin lymphomas presenting in the skin with no evidence of extracutaneous disease at the time of diagnosis. They are subdivided into cutaneous T-cell lymphomas, accounting for 75 to 80% of these diseases, and cutaneous B-cell lymphomas. Primary cutaneous CD8 positive AECTCL is a rare aggressive lymphoma characterized by cytotoxic T-cell expression, ulcerating plaques, nodules, and tumors in a patient with no prior history of chronic skin disease. It has an aggressive clinical behavior and very poor prognosis. Our patient is an 85-year-old Caucasian female with a history of COPD, hyperlipidemia, irritable bowel syndrome, and transient ischemic attack. She presented to her primary care physician in September 2019 with no onset right upper shoulder skin lesion. At that time, she was fully independent and very active. As we can see from this timeline, skin lesions worsened progressively despite multiple different therapies. Patient had her first biopsy in November of 2019, which was inconclusive, followed by failed treatment with hydroxychloroquine and started treatment on prednisone, and continued to develop multiple new lesions spreading all over her body, in addition to scalp involvement and alopecia warranting a second skin biopsy in July 2020. Soon after, in August 2020, patient presented to the hospital with weakness, shortness of breath, and severe skin lesions. On admission, vital signs were unremarkable. Physical exam findings were mostly unremarkable as well, except for the extensive skin findings, which were consistent with multiple widespread maculopapular lesions ranging between 5 to 10 mm in diameter, as we can see in these images, with severe scalp, neck involvement, and ulcerated tender nodule in the left posterior proximal thigh, but the thigh images were not included in this poster. Labs were mostly unremarkable. On imaging, CTA of the chest showed right-sided pulmonary embolism. CT abdomen and pelvis showed incidental findings with 0.9 cm hypodensity within the pancreatic neck, consistent with cystadenoma, and 1.6 cm cortical lesion in the right kidney concerning for renal cell carcinoma. The results of the second biopsy were finalized on the day of admission and showed high-grade T-cell lymphoma concerning for mycosis fungoides. Pulmonary embolism was managed with Lovenox and later apixaban, and patient remained stable. Patient received empiric therapy with cefazolin, and wound cultures were positive for methicillin-sensitive Staph aureus. Considering patient's age and clinical presentation, mycosis fungoides was less likely, and the decision was made to repeat the skin biopsy. The radiation therapy to the scalp, right shoulder, and left upper thigh was started, and total skin electron beam therapy was avoided due to the patient's poor functional status at this point. Repeat skin biopsy in September 2020, approximately 1 year after the initial presentation, was consistent with CD8 positive AECTCL. Additional testing with Cesare flow and EBV were negative, and patient started chemotherapy. Cutaneous CD8 positive AECTCL is a rare disease, and to our knowledge, there are less than 100 cases described worldwide. Overall survival is between 12 to 32 months. Diagnosis could be challenging, and it is based on the history, clinical presentation, and the biopsy findings. Due to the rarity of this condition, there are no guidelines on the treatment modality. Our patient had aggressive progression of her skin findings in the last 10 to 12 months, with dramatic decline in her functional status from fully functional to ECOG 3. Patient developed adverse effects from the prednisone, became wheelchair-bound, and developed pulmonary embolism, and later had severe anemia from the chemotherapy and opted to be discharged home on hospice care. We wanted to present this case to increase awareness on CD8 positive AECTCL, as high index of suspicion is required for diagnosis. With early diagnosis, we might decrease the comorbidities, sustain good quality of life, and allow more time for evaluating different therapeutic modalities in these patients, hoping for improved patient survival. Thank you for your time and for listening to this presentation.